welcome back to the Chatty Vets pod. I'm Brendan.
And I'm Charlotte. Thank you for tuning in.
Welcome to our third podcast of August, our next 2 Week Takedown episode.
Yeah, so this is where we aim to bring you up to date with all the latest news and products in the UK from the last few weeks.
We hope you enjoyed our bonus episode covering heat stroke and SIRS last week. Heavy topic, but hopefully one that you'll find useful in practice.
Yeah, absolutely. And remember, you've got an extra bonus episode next Sunday to look forward to too. The next of our endocrinopathy series. So we're going to be covering Addison's disease, the Addisonian crisis, and basically how to combat them in general practice.
So before we get started today, I know it seems like forever away at the moment, but it'll be here sooner than we think. London Vet Show.
Yeah, we're really excited. So it'll be our first proper event that we go to as the Chatty Vets, and we're really excited. So thank you very much to GVC for hosting us and letting us borrow part of your stand. If anyone else is planning on going, we'd love to hear from you, and please make sure you stop by the GVC stand to come and say hi to us.
And Charlotte, we need to let everyone know about a really fun talk we're doing. Caris Animal Health have sponsored us to do a talk at London Vet Show. It's going to be called Confessions of a GP Vet, Real Gut Cases and the Decisions That Changed Our Thinking. So yeah, look out for that too.
Yeah, absolutely. Definitely come and join the discussion, and keep an eye on our socials nearer the time where we'll tell you exactly where and when to find us. So keep an eye out. We hopefully will see you there. Anyway, let's get on to today's pod. So we're covering a variety of random stuff, yet again, true to brand. So we're going to be covering everything from burnout and work-life balance in veterinary to giant breed dogs and their health concerns. And we're hearing back again from Frost Dentistry about all things teeth related.
Okay, so let's get cracking. I've seen in the notes for today that you're about to bring up something really dry, which I'm going to hate. Is that right?
Yeah, I just wanted to cover it really quickly. So basically, I just wanted to say, because Brendan hates it when I talk about the CMA or the Vet Surgeons Reform Act or anything like that. And I think, to be honest, we're all probably fed up of it. But again, like I said in one of the previous episodes, it does look like things are moving. And on the 9th of July, apparently the government's published a thing called its white paper, whatever that means, proposing a complete overhaul of the Vet Surgeons Act. So it's now basically saying that these are the changes that they're proposed to include. And it's all the stuff that is said that is going to be including, like an independent vet ombudsman, regulation of vet businesses, protected titles such as veterinary nurse, licensing of practices, modernised fitness to practice regimes. So it's everything we've been talking about for a while, but fingers crossed it's now from the government level starting to look like it's going to be implemented. Now, it's still a long way to go, but I think it's good news, again, heading in the right direction. And that's all I'm going to say. We'll park it there, but fingers crossed, again, still heading in the right direction. So it's good.
Yeah, well, I'm going to highlight one bit because you said regulation of veterinary businesses. And it's not just individual vets. That's such a big thing because I had so many discussions when I was doing out of hours care with the non-vets who managed me and my region, because I'd say, well, this goes against our code of conduct, or, you know, we need to do this because of the RCVS conduct that we need to, we fall under. And they were always really good, actually. Now that's going to be not just vets that fall under that. So all those if people are managed by non-vets, they're now going to have to fulfill all of the important things that we need to be ethical and fulfill our professional obligations. I think that's a massive.
Yeah,
don't you think
definitely.
That's a biggie, yeah?
Definitely. I think it all just sounds like it's a step in the right direction. And instead of just talking about it, it sounds like now things are actually starting to get done about it, which is really great news. So hopefully watch this space, and fingers crossed, maybe vet surgeons reform will actually see some change, and it'll be some good change to practice. But who knows? Let's see what happens over the next year or so. But anyway.
Talking about change, this topic that you've come up with, I'm gritting my teeth because it's like opening up such a can of worms. I can't believe it's a good one though, because we always talk about brackies, aren't we? And bracky cats shouldn't be forgotten. I think a lot of those go under the radar. I know the Persians and exotics, but other breeds as well. I won't. This is the thing; it starts to get very personal, doesn't it? Because I know lots of pit vets with different breed dogs and people, but you've brought up this new one. Go on, tell us.
Yeah. So we've chatted, like Brendan said, we chatted loads in previous pods about responsible breeding, brachycephalics and their welfare issues. But something we've not really discussed yet are giant breed dogs and the issues that they have. So, I mean, we're talking like Great Danes, Akitas, just basically all of that stuff that you look at and you think, oh my God, that's massive. It's got to be over 50, 60 kg, something like that. And basically, there was an article, I think it was in the Vet Times actually that I saw it, I can't remember. And I think we've all known for quite a long time that giant breed dogs generally have a bit of a shorter lifespan than sort of your normal regular side, if you like, or your medium-sized breed dogs. And we know that they tend to get much more issues, osteoarthritis, they can get weird and wonderful cancers, etc. But there was some new research that was done by RVC Vet Compass is calling for discussion on giant dogs' welfare and what levels of gigantism, they call it, should be considered as meeting the threshold for extreme conformation. So the paper said that they analysed a record of about 2.25 million dogs under primary vet practice in 2019. And they found about 28 and a bit thousand giant dogs. And the most common of those breeds were like Dog de Bordeaux, Alaskan Malamutes, etc. And the median adult body weight was about 48.8, so big dogs. Okay, so sort of 45 kilos up. They found that about a quarter of the giant dogs were recording as having died with a median age of death at about 8.9 years, way lower than the median age of death of our normal dogs, so medium size, etc., at 12 years. Females, weirdly, live statistically longer than males. And the most common causes of death were neoplasia, which was about just over 12%, collapse, so about 9.4%, and cardiac issues, so about 4%. So I think they're basically just trying to highlight again. I think we all know that giant breed dogs can have welfare issues because of how big they are. But I think they're basically just trying to raise the concern again about the impacts on both the quality and the quantity of their life because of all the different things that they can get wrong with them. And I know some people are going to go, oh my God, you can't start talking about this, blah, blah, blah. What dog is going to be allowed to be bred? But I think for so long, we've just bred all of these different random breeds to such extremes. And I think, we talk about brachycephalics all the time and cavies, but actually we do need to be thinking about all the different extreme conformations that we have. And giant breeds are one of them. Like, it's not normal for a dog to be looking that big. It's not normal for a dog to look like a horse. That's not how they're made. I don't know whether this is opening up a massive can of worms, like you say, but
yeah, no, it's massively awkward, isn't it? Look, I suppose fundamentally, if you're breeding for a utility, it feels justifiable, obviously.
Mm-hmm.
I mean, I think at St. Bernard's, like mountain rescue, is there some kind of viable utility there that you can claim that there's still some value?
In the UK, but, I mean, if it's owned in the middle of a city, probably not. Yeah, it's really difficult, and I don't know. And it says, really interestingly as well, it says that quite a big proportion of these dogs that they checked, so at least 5% of the precise level disorder terms reported, aggression was one of them. And I just think as well, that's quite interesting, because I don't know whether you find the same, Brendan, but I think with your giant breed dogs, you have two ballparks of patients. You get the patients that are just big dopey BFGs and will let you do anything to them, and then you get the ones that you can't get near. So I mean, how many like Akitas have you seen that you can't even touch? And it's interesting that they've actively mentioned it in that paper as well, because what the hell are you supposed to do with like an 80 kg dog that comes in that you can't get near? It's a nightmare, absolute nightmare in practice to deal with. So if they get any sort of disorder ever that needs to be treated in the vets, it's a bloody nightmare to be able to get on top of it, because handling them is just the physical demands of handling them and lugging 80 kilos around is a nightmare in itself. But then if they're aggressive and they're difficult to deal with, it just becomes a whole nother thing in itself, doesn't it? So yeah.
God, yeah. And sometimes if you're in a branch practice, or it's just getting them on the table, sedating them and x-raying them is a nightmare. Yeah, there's a lot of logistical things. Do you know what? I think this is a bit harsh, though, overall, because we've got to go in order of priority, haven't we? You've got the brackies. I think you've got the chondrodystrophic breeds. So like the miniature Dachshunds or whatever. Surely they've got to come in there a bit sooner. I don't know. But then giant breeds are on the list. But could you go to a few other places first?
Yeah,
because they are special dogs, aren't they? I mean, I've lived with the odd giant breed Great Dane, and they're just amazing.
Yeah, and the thing is this is not me saying that these dogs are horrendous and nobody should ever own one of these. I don't think it's a question of owning one. It's a question of whether we should be continuing breeding them. I think that's the thing, isn't it? I mean, how many lovely Great Danes have you ever met in your life? And how many lovely mini Dachshunds and how many lovely Frenchies have you met? Yes, there's quite a few that maybe aren't so nice, but there's a lot that you think they can be really, really nice dogs. But it's about whether we should be keeping that gene pool going, or whether we should be continuing to breed those, because much like you say, okay, one of the welfare issues with Dachshunds, for example, is that they get horrendous IBDD, and a lot of them are euthanized at a fairly early age because they go completely off their back legs. Okay, well, you could say the same about a giant breed dog that's really likely to get DCM and is going to die when it's 6 because it just suddenly drops dead. It's still the same thing. It just might not outwardly be as sick to the owners.
Yeah,
and it's just a more sudden death.
There's other ones that aren't as people point the finger, and I feel like Maine Coons. How many Maine Coons have I had? HCM, hypertrophic cardiomyopathy, at 3-4 years of age, and
definitely.
or major hip dysplasia at 1, 2, 3 years of age, and people aren't pointing the finger there. So I just know as soon as we start pointing the finger in too many directions, it's going to be quite toxic, isn't it?
Yeah.
There's quite a few errors, really.
Yeah, it is really tricky, and it's where you draw that line. Do we say that pedigree breeding is the issue and that nothing should be pedigree bred anymore, and we sort of outcross to try and get rid of some of the horrible genetic traits that we're seeing? Is that more the general thing that we should be doing, or is it that we're saying no to certain breeds? Because it's where do you stop? There's going to be everything has certain issues. I mean, you could even say for bloody Labradors, they're so greedy in the amount that you have to X-lap. Is that a welfare issue? Because all they want to do is eat stuff that they shouldn't. It's where do you draw the line?
Well, yeah, and if you go back 20, 30 years, I used to say, well, why do we breed for pets? Why do, we've got all these working breeds that are bred for a utility. Why hasn't anyone bred the perfect pet? But then actually we have tried, and it hasn't always gone very well because we've got Cavapoos with allergic skin and ear, obviously issues. Yeah. Maybe, I know miniature poodles with patella problems and Cavaliers with heart problems, Shih Tzus with eye problems, like all the pets one. So you can't even kind of go, so then where do you end up? Like, we're trying to create something with characteristics that suit being a pet, but then we're running into disease problems really quickly. Can we do this better? So maybe, that, what was that amazing tool that I was talking about kind of 10, 20 episodes ago where where you answer 10 questions and it gives you a score out of 10. Because I don't want to create a toxic atmosphere around bloody everything, because I think you can point the finger at so many different animals.
Yeah.
Like, for example, I had a super healthy Jack Russell, but maybe you could go, well, Jack Russell's temperament ain't great. So maybe you'll get more bitey problems with toddlers or whatever, So rather than create a toxic environment, maybe it is about using tools to improve the quality of our breeding, like you were suggesting.
Yeah.
Curb the excesses.
That tool you were talking about, Brennan. So it's what did you call it? It's
the innate health assessment. It's a 10-point checklist for healthier dogs. So if we can start using this, I noticed I'm on the website now, and RSPCA, Battersea, Dogs Trust, RVC have all, I think it's Vet Compass underlying a lot of this stuff. But yeah, things like that. And breeding healthier dogs is what it's up to, rather than kind of making a toxic environment around, well, your dog's got this risk. Oh, well, then what about your dog and that risk,
Yeah, exactly. Yeah.
Minefield.
One of the other things I did want to talk about while we're on giant breeds, though, is the nightmare that they are to deal with in practice. So, I mean, I think it's probably not quite so bad in general practice when you've got a massive team and you've got loads of nurses there during the day and you've got loads of vets and you might have ACCAs and reception staff and whoever else that can get all hands on deck. But oh my God, when you've got like a 70 or 80 kilo dog, especially if they come in as an emergency or they need surgery, handling them in the practice is a nightmare. And I mean, especially because I work overnight and it might be me and a nurse or me, a nurse and an ACCA if I'm lucky. And I had one fairly recently where I did surgery on a big dog that was about 70 kg between the 3 women and us trying to get a 70 kilo dog onto the table to anaesthetize it and do it safely for us and safely for the patient is hard. It's really tricky. And I know everyone always says about all the safe manual handling and stuff that you can be doing, but honestly, sometimes it's just a bloody nightmare, isn't it? And you're like, right, how the hell are we going to get that thing on the table? Especially if you're not lucky enough to work somewhere that has those tables that go up and down. It's just horrible,
I was going to say, I never feel more happy than when I've walked the giant breed dog onto the table because you've lowered it right down, and then you just sit there with a button and you goes up, and you're like, ha ha ha, I've done it. Because then once they're on the table, you can then adjust the table height, can't you? And then just push them onto the X-ray table, or push them onto the theatre table.
Yeah,
that is a godsend. But you get it in general practice as well. When so I've been in clinics with no walk-in kennels, so then they have to have a room. So usually it's X-ray room. I find is like the room they go in or whatever, and you've got them on a spiral giving set or something.
Yeah.
Obviously they're now in a room, so they often can do quite well. But they're a management headache for us.
Yeah, they are. It is a nightmare. And even if you have big kennels, if you've got one hospitalised, trying to get behind it to take its temperature when its butt is right up against the wall because it's just not big enough for it. It's just, they can just be such a headache to deal with, can't they? But anyway.
I think you have to be really cognizant as well on the consult that your giant breed consult is a whole different level of stuff. There's so much logistics in a giant breed, because of these reasons. The owner, if they're a little bit poorly, they can't carry them out for a wee and a poo. They can't go on a walk if they collapse and you can't carry them back. And there's so many things that you have to tackle differently in the consult because they're now a really big breed that can't be carried. Yeah, I don't know. I'm really mindful of how I talk about that. And I'm probably going to euthanasia sooner in a giant breed dog, just from the logistics, from the owner's point of view.
If you've got like a spaniel, for instance, and it starts to get to the point where it's really struggling to get up, and you're just saying, okay, pop a towel underneath its belly, give it a hand up once it's up. If it's comfortable, maybe you might be more inclined to keep those dogs going for longer, rightly or wrongly. If you get a Great Dane that's 80 kilos and it can't get up, you're not getting that thing up. Like, that's not going to stand. So it's, it's like moving a horse. It's just, it's not going to happen. So I know what you mean. You may be jumping towards different outcomes sooner than you might be for other breeds just because of the logistics of it. Yeah. So it can be really difficult to manage, definitely.
Have I told you about the Great Dane I lived with that when she had her first season, and I think we hadn't put the pants on her, or she just used to chew them off. I can't remember.
Yeah.
But boy, like having a golden retriever or a spaniel with having a season, fine, not a big deal.
Yeah.
Having a Great Dane, the height alone, that the blood is like at a 3 foot high level around the room. Oh, it's something else. And then now giant breeds, delayed neutering, 3 seasons. If they want to, and like our golden retriever, she'd eat her. She couldn't wear the nappy because she'd just eat it and chew it up.
Yeah, basically what we're just trying to say is there's nothing wrong with owning a giant breed or having one, and they can be the loveliest of dogs. It's just opening up that conversation to be saying we should generally be thinking about responsible breeding in terms of all of our pets now, and what can we be doing to helping welfare in general, not just specific breeds, because there are a lot of other issues in different breeds that we might not think about all the time. So it's about that quality of life, isn't it? And just trying to improve that as much as we can and thinking about what we can do long term.
One little thing with the giant breeds, until you've lived with a giant breed dog and that enormous head that is the size of another human, it's like they've got the presence of a human in a really wonderful way. And I think to me, there is a kind of magic about a giant breed dog. Now, I know we're talking about some of the negatives, but for me, compared to all the other dogs I've owned, there's something different about the sight, that having that head on the sofa, looking at the TV that's like that big, it's just, it's a bit magic. But go on, carry on.
Yeah. I think they can make wonderful pets, can't they? But anyway, moving on to something else that I saw, which actually I think could be quite cool. So there was an article that came out and said that there's a new quality of life tool that we can use for cats. So apparently there's something that's been developed by, I think it's called Waltham Pet Care Science Institute. It's been in collab with a few places like Uni of Bristol, Royal Canin, Mars. And basically they've developed and validated a new tool to help clinicians and cat owners assess feline quality of life. So apparently they did a 2-part study. They're describing it as the most comprehensive of its kind, apparently. They've got responses from just over 1,300 UK and US cat owners. And it comprises about 37 questions requiring the owner to evaluate things like the cat on a scale from 1 to 7, covering 7 domains such as activity, how talkative they are, how satisfied they think they are, how relaxed they are, how mobile they are, what their appetite's like, whether they're sociable, etc. And it basically uses that with it, apparently it only takes like 10 minutes for the owner to complete as well. So I think compliance is pretty good. And they found that there actually is some statistical significance. So the active and satisfied domains are said to have differed significantly between breeds, with long hair cats scoring low for both. Siamese cats scored high for active, and Maine Coon cats scored high for satisfied, whatever that means. I'm not sure what they mean by satisfied. How can you tell that the cats, does it mean like
Smug.
whether they think it's happy? Yeah. I don't know. Sounds strange. But anyway,
scale.
Yeah. Regardless, it just basically they've said that it could be a really powerful tool, especially when tracked over periods of time, to say, okay, has there been a change in a pet's quality of life? When do we think that quality of life is declining? And also, they've said it can actually be useful for pet owners to realise when something's changed and not quite right. So say, for example, if you were to implement a tool like this when they're 2-3 years old and you have a score that this patient is getting, if you reminded them after every booster vaccination that you're doing every year, so refill in this tool and just say, keep an eye on the number that you're giving them. And if you think that score's declining, come back and we'll have a little chat. And I think that's actually quite interesting, isn't it? To say, maybe it's a good way to swing it back on the owners and to say, you come back if you think this is changing, because these are all the things we want you to monitor. And maybe you could come back and have a chat to us if you're worried about something changing. So I don't know. I mean, what do you think? I think it could be quite interesting. I've not actually seen the tool yet, so I'd need to have a little look to see whether I like it, but it could be interesting.
Right. The thing with this is all the good owners will do it, and they're already good owners. They know how their cat's feeling already. And all the bad owners won't do it, and they'll still be bad owners. So there will be a sliver of good owners that do it that aren't aware of what the cat's thinking. But, maybe. Do you know, I know when the cat owner's a good cat owner because the history is like, when they'll say observations about their cat when they're a good cat owner, or that's not good, is a bit unfair, isn't it? When they're really engaged with their cat, and they'll go, they'll know every little aspect of their behavior in terms of their drinking and their pooing. But the bad cat owner's just like, yeah, not right. Yeah. And you ask them all these questions, they've got no idea. Is he eating? Well, I don't mind, but the food's still there. You just you do get a little clue how engaged the owner is in their cat. Maybe if you pick up that they are quite engaged, this might be the tool for them.
It's just really nice that there seems to be, as the years go on, there seems to be more and more coming out for us to use to be able to improve the way that we treat our feline patients, the way that we monitor them, the way that we get owners to monitor them at home, and the way that we can improve their welfare. And I think if this is another tool to add to our arsenal to help improve their welfare, then great, I'm all for it. It's just trying to get it implemented into practices. But yes, just something to keep an eye out, have a little look, and if you like it, then maybe it's something that you could add to help in your feline cases. So yeah, there we go. I've seen on the script, Brendan, you've got another one of your little ranty topics that you want to go on about next.
Oh, no, I'm going to get a reputation.
Go on, I know you want to.
Go on. Oh, I'm going to get excited and animated now, aren't I? No, I got really irritated. I think it was the American Association of Hospital, whatever's, AAHA. They came up with some regulations where they were like, you got to change the IV cannula after 3 days. Have you come across this? So then, and I hated this with a passion. But obviously, it's a massive organisation. I can't go, well, I don't want to. Well, I might have said I don't want to do that. But anyway, I used to sometimes see this most beautiful IV cannula that's been in for 3 days, not red, looks wonderful. And the nurse would be like, yep, it's day 3, we're taking it out. And then they like stress the poor little cat out, putting another one in. You've taken the tape on and off, and the skin's got a bit red and sore. And I just think, that's naff. But I was really pleased to see that the 2024 AAHA guidelines have ditched just take it out after 3 days. If it looks wonderful, leave it in. There's more problems if you take it out every 3 days. So right back at you. For 15 years, I've been angry about this. I'm like, yes. Is this, what do you do? What do you find the staff around you do?
Yeah. So, I mean, everywhere that I used to work always had that 3-day rule. And I never really understood it either, because I was like, well, if there's no evidence of any vasculitis and it's patent and it's being cared for well, then what are we doing? But I think one thing that we should be moving more towards is like what they do where I work now, is on your hospital sheets, have a little point for twice a day where you're unwrapping the bandage and you just have a look. Is there any redness? Is there any swelling? Is it flushing nicely? And remember to sterilely flush those catheters multiple times a day to keep them patent, especially if they're not on fluids or they're on a low fluid rate. So you keep it patent. And I think that's the most important thing. And if you're being sterile with them, if you're being careful and you're continuously checking them and flushing them, keep them in until they no longer work. Like, unless there's any signs of phlebitis, then yeah, absolutely take it out if you need to. But especially with sick patients, you end up running out of legs if you keep changing because you blow all the veins and then they need another one put in. You're like, oh, fantastic. Where do we go now?
Also, if you've had a lovely cannula that's been doing a great job for 3 days and it's looked beautiful, that doesn't always happen. You know, if it's not taped in perfectly well or the patient, you know, I just think once it's in, it's doing its good job and it's not red and it's flushing lovely. Yeah. But anyway, you can't help but feel like, you know, certain things just get you. That gets me. But do you know what? One thing that I've changed my mind on, I used to get really irritated by, you know, the little sachets and you open them up and you've got the little wipe for the Chlorhex. I used to be like, well, that's like it's bad for the environment. It's like more packaging and da-da. Actually, they're pretty cool because they're the right concentration. You can have everything ready in a little tray where you got your little pre-done, you know, you got your sachets. And I've actually, I used to be grumpy about that, but now I'm like, no, they're actually quite good.
They are good. And I think if you go on the environmental side of things, pretty much everything in veterinary is rubbish. Your autoclave bags, all the plastic packaging that we have for everything that we use, all the consumables, everything is one use and chuck it away. It's really bad. You know, people use disposable gowns, disposable drapes. It's like when you look at how much crap we use, your isoflurane, how bad is that for the environment? You know, there's so many different things that we use that I think the whole industry probably needs a bit of a shake up in terms of environmental standards. But that's a discussion for another day,
in terms of we as a profession, we're all like animal lovers. We all like care about, we all go, oh, I want to go into wildlife. I want to do this. And we're absolutely trashing it because we sell flea and wormers for the last 50 years that have been like killing the bee population. Like, do you know how many, like 20 years ago, like people, you know, when they brush your dog and they go, oh, I'm going to put my fur out for the birds. But it's like covered in all the toxic chemicals we've been selling them. So like it's killing all the little birds. And so many things that I look back and think, oh my God, we're the worst, aren't we? We'll deal with that in another episode, actually, I'm sure.
Yeah. Maybe we park that discussion for another day. But anyway, I wanted to move on to now. I know sometimes we like to chat about cases that we have had in practice from time to time. And I had one fairly recently that I thought was worth discussing. Brendan, you know, I mentioned to you a little while ago when we chatted about aspiration pneumonia cases, and both of us were like, oh no, normally it's not that bad. Normally they get aspiration pneumonia because there's something else going on. Like, I don't know, they've been seizuring.
I didn't say that. I said, no, go back on the episode and look. I don't know. I don't think I'd have said that because I'd have said, normally they're absolutely fine. But every now and then they will die in 6 to 12 hours. They get like this super duper sepsis thing. And they're just, they ain't coming back from them.
Basically, nearly every case that I've ever had has been kind of okay. Like, you know that the aspiration pneumonia is bad, but usually it's because they've had something else going on that's been making them sick. And then they get the aspiration pneumonia secondary. And then usually it's because of the overwhelmingness of the pneumonia on top of everything else that's going on that sometimes means that you go for euthanasia or it dies. I think I told you about this case I had recently, and I won't say where or what type of dog or whatever, but basically I had this dog come in who, for whatever reason, again, I won't give specifics, but had developed an aspiration pneumonia. And it was an aggressive dog as well, which again made the handling of the case super difficult. But the difficulty is that when it got to me, it wasn't blue, it wasn't orthopnic, it wasn't like elbows out, head extended, really struggling to breathe. But I was like, I know that it's coming. Anyway, I scanned its chest and it had coalescing bee lines all over both sides of its chest. And I thought, this is bad. This is really bad. And it's going to get really bad soon. But the owner doesn't realize how bad it is yet. So I said to her, I was like,
Do you know it's aspiration pneumonia there? Because it's not just 1 or 2 lobes affected. Yeah. What's the background? Can you say enough of?
It basically had inhaled a lot of horrible liquidy solution for a reason that I knew that it was because it had inhaled something. It was situational. So I knew from the history that it had aspirated. So basically what happened is I said because I had to sedate it to even be able to examine it, did my POCUS and got an IV line in, put a long line on it because I knew I wasn't going to be able to deal with it when it was awake. And I said to the owner, I was like, it's not that bad yet, but it is going to get bad. And I don't know how bad it's going to get, but I know it's going to get worse. Anyway, I admitted this dog, we're really lucky where we are, and we have proper oxygen cages. So I can put them in an oxygen cage, adapt the humidity and the temperature and the FiO2 and all that sort of stuff. Anyway, put it in the oxygen cage, was doing okay for about 3 hours. And then at about 3.5 hours, typical orthopnic, elbows out, head extended, was really, really struggling. His respiratory effort had gone through the roof. And at this point, it was still awake, so I couldn't examine it again. I just had to monitor from the outside, give it IV meds as much as I could to try and fix it. And about hour and a half after that, I was always keeping an eye on it, but I looked at it and thought, why are you now in lateral? You've either suddenly become a lot more comfortable or you suddenly got a hell of a lot worse. Anyway, I put my hand through the little hole in the front of the oxygen cage, because they use it so we can examine them or do T-pokers or whatever. And I just thought, I'll touch it, and if it doesn't try and bite me, I know it's bad. Put my hand in, it didn't turn around to bite me. And I was like, oh God. So pulled it straight out of the kennel, screamed for my nurse, ran the dog through into prep and tipped its head downwards on the way through. It absolutely poured fluid from its face, like poured. I cannot describe to you how much fluid came out of this dog's nose and mouth. And it was like that horrible, it looked like pulmonary edema fluid. It's like that horrible serosanguinousy, frothy, horrible fluid. Anyway, it poured out this dog, and we managed to get it onto the prep table, intubate it, get it on some oxygen, IPPV it, still it started breathing properly again, and we got it back. I basically had to keep that under a propofol CRI, intubated on 100% oxygen, and we kept going for about 36 hours. We don't have a ventilator, and it obviously wasn't stable enough to move. But even when I was getting a beautiful trace on my SpO2 was reading 56%. And I was like, this is bad. Below 80 is bad. 56% is not compatible with life. And it was just awful. It was one of those horrible cases, again, where you do everything you can think of. And it's the really horrible thing with pneumonia is you just have to wait. Like, you just have to wait and see if it gets better, because there's only so much you can do. If you're giving it oxygen and you're providing the meds that you need to give, ultimately it's either going to get better or it won't. And the dog ended up crashing, and it was awful. It wasn't a very nice situation, but it's just, I fully take it back. They can be absolutely horrendous on their own. I've now seen one. I will never say that again. It's just not nice at all.
In my GP caseload, I think like 1 in 10 to 1 in 20 can be in GP world. You're not going to save them.
No.
Like, the context for me is normally post-op after a GI case. They've had some aspiration, and a lot of the time, absolutely fine. But nowadays I'll just go, just now and then it can go really bad, and then But do you know what I wanted to talk about when you were telling me that awful story? Is this kind of, is it moral injury, or this kind of, you're in an environment where you're dealing with severe, awful things for hours, horrible situations, and it's like an injury that it's horrible to experience, isn't it? And I think when I hear you talking this, and you might look back in a year or two or whatever and go, wow, yeah. Or do you feel it now? I know the medics have this where a lot of their caseload are dying. And I know, and you start to have to get used to 60% of your patients dying or whatever. That's hard, isn't it?
It's really hard, yeah. And a bit later in this episode, we're going to touch on burnout, compassion fatigue, etc. But I think when I was in GP, there were cases that hurt, and there were dogs or cats that, you'd known for a while and they died eventually. And it's always sad when something gets older and then they make the decision to euthanize and blah, blah, blah. There is a different level of hurt and sort of the case sticking with you when you have hospitalized the patient intensively. And I mean, like a nurse with it 24/7 for 2, 3, sometimes longer, 7 days even, and then it dies. And that is heartbreaking. It's so hard, because not only have you put your heart and soul into trying to save that pet, but for that whole time, there's a little bit of you that still hopes that it's going to pull through. And I think that the chances are slim when animal is that sick. But to eventually, I mean, I'll remember that case for the rest of my life. It was horrible and it was awful. And, we all did as much as we could have done, but it's still, that dog is no longer with us and that owner no longer has their pet anymore. And it's just it's a horrible thing to be a part of. And there's always part of you that feels guilty, because even if you did absolutely everything that was within your power to do, you still feel partly like it's your fault, which is a really difficult thing to come to terms with, isn't it? And I think medicine is one of those professions where there's not many other people that can really understand that. There's only a very set few professions that will ever feel like that in their life because of something they've done at work. I definitely went home and had a bit of a cry about that dog after the case. It's it's not nice. It's like that heat stroke case that we were talking about last week, and that was awful. That was absolutely awful. I did everything I could not to cry when we put that dog to sleep. It was horrible. But it's,
do you know what?
Yeah, sometimes they just stick with you.
Yeah. When you're describing these cases, I can't help thinking there'll be some people that go, "Oh, I'd never have gone that far. I'd have just euthanized it, 3 hours ago," and they might even feel a bit, I wouldn't have been in that situation. I'd put it to sleep. My animals aren't going to suffer that much. However, when you've worked with some people who are so good and there's been a crashed patient that's doing really badly and they fixed it, that's the moment in your life where you're like, you can sometimes fix that really critical one. But then you get the dilemma, but when do you don't know.
When do you call it? Yeah.
When do you call it? So it's easy. Yeah. It can look easy to go, no, euthanize. But actually, when you've seen I've seen a few turned around from dire situations where we've done CPR twice and they're living a great life now. And you're like, okay, now it's really hard.
Yeah. And I mean, don't get me wrong. I think I'm definitely more on the side of things where I'm not pushing as far as a lot of other people would. And that's not because it's wrong to do so. It's just that I feel like my line is a little bit, I maybe wouldn't do as much as some other people would, especially for my own pets or anybody that asks my opinion. But I mean, this dog in particular, the Aspiration pneumonia one, was very young and the owner was insured up to about 15k, so money wasn't an issue. And I know that shouldn't be the reason why we keep going, but there was no reason to stop apart from the fact that it might not get better. But it wasn't suffering in that we were keeping it comfortable and it was anesthetized. So you sort of think, well, maybe. And we knew that we were going to call it if it did get worse. And unluckily, it was just one of those things where it decided to take that option out of our own hands and crashed. But by that point, it was a DNR. So we made that decision for the dog. Yeah, it's hard. It's really hard. And I think you always do wonder, should I have called it sooner, or should I have done this, or should I have done this? And that's when, like, your morbidity and mortality rounds, if you run them in your practice, and if you don't, maybe you should run in your practice, because they can be really useful for these cases. But again, in GP land, you're probably not seeing them that often, but it's when you do see them, they're horrible and they're really sad.
Stop that thought. Mortality round. No, what we need is, who told me this? I can't remember. So, was it on the? I don't know. It was with you. She said to do what's the opposite of a mortality? If you have a really good case, we should present that. What do you call that? What's the opposite of a vitality round or whatever? Because that's so much more positive, isn't it? And actually, you can get just as much learning from how to do things really well and a really good outcome. In fact, that's much more pleasurable for everyone and more engaging, I think, than these miserable. So yeah, make it a vitality round and go over a case that you've done really well. And I reckon that's even better. Yeah. Is that something you've come across?
Yeah, I've not seen it done, but I think it should be. Definitely. I think it really should be. But again, it's having the time in practice to have the time in practice to go over cases with your colleagues anyway, apart from just like informally over a cup of tea, is really tricky. And then trying to fit in all of the cases that have gone well and the ones that you need to talk about to make sure they don't go wrong again is really difficult. And nobody has the time, do they?
We've had some heavy chats at the moment. We're going to go heavy again, aren't we? We've got something a bit different now.
Yeah. Well, I wanted to talk about something a bit funny first before we go on to something else. So talking about that Aspiration pneumonia case, do you know what always annoys me with these cases? The bloody SpO2. It pisses me off all the time because you think, is it accurate? Is it not? They never bloody read right. They slip off the tongue gets dry. And I saw a paper recently and I was like, oh my God, maybe this is it. Maybe we found a way around it. Maybe there's a new way that we can check their oxygen sats and it's going to be amazing. And anyway, there's this paper that came out and it was using something called the Owlet Smart Sock, which apparently is like a thing that you put on human patients. I think it's used for like pediatric patients. In theory, you could use it on an awake patient and put this like sock thing on them, and you use it as a patient monitor so that it's easier and you don't have to put it on like a tongue or whatever. And I was like, amazing. How cool will this be in our veterinary patients? You know, you can just put this sock on them in a kennel and then it's going to read your SpO2. Anyway, clinical significance of the study turned around and said, peripheral oxygen saturation measurements showed limited agreement and should be interpreted in caution in general practice. And I was like, oh, okay, well, it's not useful at all then. So I was like, oh, good. Okay, so we've still got the shitty SpO2. Lovely.
Yeah, because all of our dystonic management is rubbish, isn't it? Because essentially, in the patients that are awake, we can't measure their blooming PCO2. Most of us can't do an arterial blood gas. So we're pretty much, would they need supplemental oxygen? We don't know in most cases. We might know if their PCO2 is high on a venous blood gas, if we're in like out of hours practice or whatever, or you've got an ISTAT machine, and that's helpful for ventilation. But for oxygenation, we're mostly really in the dark unless they're absolutely knocked out and we can stick something on their tongue. Yeah. Or we've got the arterial blood gases, which, maybe, have some kind of more value there, but they can lag behind the troop. In a perfect world, we'd have that SpO2 from a pulse oximeter. So, totally with you. We desperately need it.
But anyway, enough of us gabbing on. We figured you might want to hear from someone else for a while.
Yeah, so we thought you could do with a break. Do you remember a while ago, we interviewed Jonathan from Frost Dentistry? Well, we had such a good chat with him that we didn't manage to air the whole video in our previous podcast, so we wanted to share a bit more with you now. You mentioned daily brushing. Sometimes when I'm chatting with owners, I might just go, well, even if you can do it 2 or 3 times a week, it's better than not. Yeah. Or what's your take on that?
So, another shameless plug quickly. On my website, it's frostdentalvet.com. There is a free to download toothbrushing guide aimed at which you can print out and hand to owners, and it's basically an instructional guide on how owners can train their pet to have their teeth being brushed. Because if you just get a toothbrush and toothpaste and go for it, you're probably not winning. But if you train that animal, over kind of a couple of months, you have a much better success. And I've met some animals which, unfortunately, you'll never win. But also I've met some animals which, after training, you do a fantastic job. And I know an owner who uses an electric toothbrush once a day on their cat, and the cat loves it. But I would say, there are, from a toothpaste point of view, 90% of the benefit of brushing comes from the mechanical action of the brushing rather than the toothpaste. Often toothpaste is flavoring. And there are a lot of toothpastes that market themselves in various different ways, having various different ingredients and so on. But in all honesty, I would recommend using whichever toothpaste you are actively going to use.
I was going to say to you seem to get a lot of cats that have like a really nasty gingivitis when they're quite young, and they don't seem to have concurrent other cat flu symptoms or anything. And a lot of the time people are going, I don't want to pay for a dental right now. It's really young. I don't have the money, whatever. So I'll send them home with Stomidine to start off with and say, let's give it a go. Or maybe some anti-inflammatories as well and say, let's see how we go for a week or 2 and then we'll recheck back. But I mean, what do you find is often causing it in those guys, and what do you do?
That answer is fantastic. I like what you're doing. So what you're probably seeing there is essentially what's called a juvenile gingivitis, which it's something we see in young cats, often 6 to 12 months old, where they just get this very, very severe, like almost an overreaction to the plaque bacteria. So they get very significant gingivitis, the gum's very inflamed, but it's not a gingivostomatitis. Because we're not seeing that kind of the stomatitis lesions, we're not seeing that caudal issues. And it's a really weird condition that it's related to the plaque bacteria. If we can control the plaque bacteria, then they age out of it. So by the time they're kind of 18 months old, it starts to settle.
Yeah, that's so cool. Never heard of it.
Yeah, it's a bit of a weird one. And it's something that a lot of dentists will see referred to them as gingivostomatitis, and they're being referred for a full mouth extraction at 6 months old, but actually they don't necessarily need that.
Yeah.
There's the other things which I'm wondering if you're not going to be a fan of, because every vet waiting room has these on the shelf. I think they have the plaque off, and they have or equivalent, and Aquadent or the water, this thing that goes in the water.
There is science behind those. There is in the plaque off, basically, it's basically made of a seaweed extract. And there is very good research that indicates that seaweed extract can reduce plaque bacteria in the mouth. I wouldn't recommend it purely as the only oral home care, though. Using it in combination with your brushing and your potentially specific foods can help as well. But I wouldn't necessarily jump to that as the only thing. But having it as an additive can help. The problem is these products, some owners are buying these products and they're saying, right, because I bought this and because I'm using this, I don't need to worry about the teeth. I mean, it kind of lulls them into a false sense of security. And that's the same thing with dogs going to groomers and having groomers cleaning the teeth. They go, let's say you've got a little cockapoo, it goes to the groomer every 8 weeks for a trim and they clean the teeth at the same time. And the owner's not seeing any visible calculus on the teeth because the groomer's dealing with that. And so the owner goes, well, my dog can't have dental problems because, he goes to the groomer and has it cleaned. But plaque bacteria takes about 4 to 6 hours to grow after you brush it off. And it's the same in you and I. If you brush your teeth in the morning, by lunchtime, you've got plaque. And if they're going every 6 weeks or 6 to 8 weeks, then there's a lot of time for that plaque bacteria to grow. The groomer isn't getting all into the gingival sulcus and missing all the little nooks and crannies. So owners think that their dog can't have any dental problems, but actually under the surface might be a very different story. So I would always stress to owners that they're potentially being lulled into a false sense of security. And then there's the whole added thing of anesthesia-free dentistry, which is another rant I could go on for quite a while. Anesthesia-free dentistry essentially is the cleaning of teeth and treating of dental problems without your patient having an anesthetic, which, as you can imagine, is a terrible idea, because how many animals are going to sit still for a good, thorough oral exam? In order to know what's going on with teeth, we need to do a good oral exam. We need to use our periodontal probe, assess gingival sulcus depth, assess any pockets, assess mobility, looking at all the weird nooks and crannies at the back of the mouth, which, an awake animal, it's not going to work. And then cleaning the teeth. You, same as me, use an ultrasonic scaler. The tip is vibrating very, very quickly, and it's spraying water. You try that on an awake patient, it will hate you forever. So we do get some groomers using these, and unfortunately I've heard of some vets as well, or some vets practices, using these kind of ultrasonic machines that are meant to be, that don't produce water and everything like that. And the problem with that is you're not getting all the problems. You can't clean the gingival sulcus because your patient just won't let you. That is a painful thing, or it can be a painful thing if you're applying too much pressure. And so you're not doing a thorough job. You're potentially missing problems because you're not water cooling your ultrasonic scaler. The tip gets hot and you can get thermal damage to the teeth. So I would say, the Royal College and the British Veterinary Dental Association do have a firm statement on anesthesia-free dentistry, which echoes what I'm saying really, which is as a profession, we shouldn't be recommending it. None of us got into this profession to cause pain in our patients.
Yeah. The other thing that I wanted to circle back to, Jonathan, if it's okay, when we were talking about gingivitis and gingivostomatitis in cats,
yes.
If you have a true gingivostomatitis, I think a lot of us were taught at university, it's probably Kalichi related. Total mouth extractions is probably what we should be doing eventually. I think that's where a lot of people have been taught. Maybe bar the canines and the incisors, maybe. But I mean, in terms of what's your stance on it? What would you say is sort of the modern way to do things?
I would say it's not technically true to say the disease is caused by Kalichi virus. Statistically, 60% of all cats with gingivostomatitis have Kalichi, but then 30% of cats have Kalichi anyway. So it's not statistically significant enough to say that Kalichi causes this. We, in fact, have no idea what causes gingivostomatitis in cats. And there's a lot of research being done at the moment. But essentially, medical management alone is often not satisfactory. It just doesn't get you what you want. And historically, the medical management used to be give them steroids. Steroids are wonderful drugs. With cats with gingivostomatitis, it will make them feel better temporarily. But it's not fixing the problem. They're still going to have their gingivostomatitis. And actually, the more steroids we use, the less effective we find that other treatment options become in the future. So I will only reach for steroids in those cases when we've exhausted every other option and we just need quality of life. So I will go down a surgical route to start, and I prefer to start with subtotal extractions. So all the premolars and molars in one go. And I tend to find that has a very good clinical outcome. Then we review that patient in a couple of months. If they still have notable stomatitis, then we progress to a second stage of all the canines and incisors.
Wow. Okay.
So then the cat has nothing. But that in a small number of patients, we still see refractory cases where they still have that inflammation. Those are really nasty ones. And I would always want to make sure your cat doesn't have FIV or FELV, which is going to significantly impact the resolution. And then if we're still getting these refractory cases, then I like cyclosporins in those cases, and also interferons as the other option. So they're both kind of either of those is the medical management I would try, in combination with pain relief and such.
On the feline oral pain issue, FOPS, Burmese, is that just immaculate teeth? Is there any, I think, is phenobarbital still the thing? Or
so it's a really weird condition, that. And from a diagnosis point of view, we diagnose by excluding everything else, essentially. Burmese are, I would say, overrepresented in it, but I've seen this in other patients. And it can be kind of an idiopathic pain, but it can sometimes, I've seen facial pain syndrome developing after the dental work, for example. And that can be a case of, whether it might not necessarily be that true facial pain syndrome. So we want to assess and make sure there's nothing else going on in the background. So we anesthetize them, we x-ray all the teeth, we look for any, are there any root tip remnants, are there any resorbing teeth that we might not have noticed before, have they had surgery before where potentially someone has pranged a nerve or something like that. And then if we are not finding anything else, then we kind of have to look at the more kind of neurologic or neurogenic pains. So I find gabapentin can be quite helpful in those cases. Gabapentin's a wonderful drug in cats. It's and I've seen some quite interesting improvements in patients using gabapentin for that. But it's not a particularly common condition, I find. Often, animals that get sent to me to investigate kind of that facial pain, often we're finding something else going on. And so you kind of have to rule out everything else first. But definitely Burmese are a bit more represented than we would like.
I was going to ask you, a lot of places that I've locumed in the past have been really for sort of 2-stage dentals. What do you think? Do you think it depends on skill set and how long that person is likely to take? Do you recommend getting them all out in one go? What would you suggest?
I would say, personally, my view is it should depend on how long you think the procedure is going to take, but also how stable your patient is.
Yeah.
We had a cat earlier on this week that we had essentially 4.5 hours worth of extractions in a 16-year-old hypothyroid cat, and rock solid anesthetic. Because the anesthetic was stable and the patient was stable, temperature was great, ECG was good, blood pressure was lovely, I was happy to continue. I've also had patients where an hour in, your blood pressure's tanking and your patient isn't happy. So I would say, if you feel that you can do the work safely in a sensible time frame with a patient that's stable, fantastic. I personally see nothing wrong with going, right, we've done this much. I'm not comfortable with doing the whole anesthetic in this patient. So we dealt with the first half, we wake them up and we see them another day. And for that reason, whenever I'm doing any dentistry, to be honest, I'll always try and start with the worst teeth first, or the most painful teeth first, most problematic ones. If we do have to stage it for anesthetic concerns, then at least we've got kind of the nastiest stuff dealt with first. There is a bit of a growing trend for coming and having anesthetic. You're cleaning, you're charting, you're x-raying, identifying problems, and then saying, right, we'll see you in a month's time to treat the problems, which I'm in two minds about. You're identifying problems, you can make a very nice plan, but then your patient is having a second anesthetic, and it might be that what you were finding could easily have been dealt with in one procedure. I would personally just get started, and then if you have to do things in 2 stages, you do things in 2 stages.
Thank you so much to Jonathan for coming on the podcast. We appreciate it. But before we finish up today, we wanted to dive into another big topic within vet med that gets spoken about but maybe doesn't often get as much attention as it should do. I know I feel like the last couple of episodes we've got a bit heavy and have talked about some really heavy cases, and apologies for maybe going back to heavy stuff again, but we wanted to talk a little bit about burnout, getting absolutely so burnt out in practice that you feel knackered and you feel like you can't do it anymore, experiencing compassion fatigue, etc. It's something that we see all the time, isn't it? It seems to still happen quite regularly across vets, vet nurses, people in practice, doesn't it?
Yeah, do you know what? And I think the term burnout's not quite right in a way, because I think there's a whole bunch of people that they're trying to do something else with their career rather than the clinical work, because it's just so emotionally exhausting. And they might not be, well, they might be burnt out, yeah, but they're not necessarily looking burnt out. They might be just cracking on with it. But if there's a job that involves non-clinical work, then they're going to be running for that door and going there as quick as possible. It is because of this emotional impact of the clinical work, the day-to-day clinical work. It's bloody hard, actually. And I'd rather, I'd still do it full time, obviously, but yeah, even after 26 years, it can be a little bit too much. I don't know how to explain that.
It is. I mean, when you think about the job in general and you think about all the different stresses you get, the hours, the maybe really tricky clients, the fact that we're all probably perfectionists and we're all trying to strive for being perfect for our patients all the time. Now maybe social media coming into it and the sort of stress we have from clients saying that we're too expensive and that we need to lower prices, and maybe not being able to treat pets because people have no money. The targets that maybe the corporates that you work for are trying to push you to meet. Are you making them enough money? Are you running enough bloods? Blah, blah, blah. Compassion fatigue, like getting emotionally drained from all of the different cases you see. And that compassion fatigue for maybe just keeping caring for all these different patients, and then just getting to a point where you feel like you've not got any care left in you anymore, because you just, you do get to a point and you just feel run down. And I think that's not us saying that, because there's a lot of people that are listening to this that are probably new grads or are just finishing vet school. And that's not to say that the profession is shit and we're trying to put you off it. But there are lots of things that can make you feel exhausted in this job. And I think it's just that reminder to ourselves to just keep a check on yourself and your colleagues. Is that person coping okay? Are they suited to full-time work, or do they, for the practice and the life stage that they're in, is it worth them going part-time and doing something non-clinical, like you say, Brendan? Are you suited to being a vet or being a vet nurse, but maybe not in clinical practice? Is it a bit too much for you in terms of, emotionally, are you coping? And I think we forget, because everyone always says, whenever I've spoken to anybody about leaving the profession or considering doing something different, everyone goes, but what a waste. You put in all that time and all that training, and what a waste. And you think, yeah, but it's a waste of your life if you're doing something that doesn't quite suit you. And I think that's the thing. It's not to say that maybe veterinary in the profession isn't for you, but sometimes that job or that situation or that level of work or the hours maybe just isn't the right thing for you. Do you see what I'm trying to say?
I know, but I'm just thinking of you, Charlotte. You work far too hard. You do far too many hours. This is you. Like, you are. Well, you're like, we're talking about yourself. I am as well. I think you're like an Uber version of me. Like, I think you're even worse. I don't know. We both work too hard, and then we kind of feel a bit deflated and lack a bit of oomph at times. But that's where I depend on the support of the people around me. And I think you made a really good point. We need to be mindful of our colleagues, and we're trying to support each other, because we're all suffering, and we need that help. And it's critical,
and
isn't it?
To sort of have people around you that get it. Like, I mean, I sometimes, so after I've done a week of nights, like I had not a very nice week a few weeks ago where I had some super emotional cases, and I was driving home on my long drive, and I called my partner, and by the time I got home, he knew that I wasn't going to be in a great mood, and he was just like, let's just have a chilled evening in, and let's just not talk about it, talk about something different, just watch a bit of telly, because when sometimes you're exhausted and you can't even be bothered to have a conversation about anything, you just feel like you don't want to talk to anyone. And it's having people in your life that just get it. They might not understand it fully because they're not living the job with you, but having people around you that can just support you through it, because sometimes you don't want to talk about those cases again, you don't want to rehash it, but you just need someone to just show that they're there for you and just to help you work through it emotionally. it can be hard. It can be really hard. And I think trying to deal with that emotional side of it when you're exhausted because your body's tired, because we're doing a physically demanding job as well as an emotionally demanding job, it can be really difficult. And I think people would be lying if or I don't know, maybe I'm different, but I think the majority of people in practice would be lying if they have said that they've never thought about doing something different. I think that's what I would say, because I think it all goes through everyone's mind at some point, after a particularly bad week or a particularly bad case where people go, I don't know if this is the right thing for me anymore. And I think people go through it in waves, and hopefully you're one of those lucky people that doesn't feel like that very often. But I mean, they say, because I remember being taught at vet school, they were like, get ready for the 5-year mark, because everyone always says that, people start to approach the 5-year mark and then a lot of people start dropping out and doing something different. I'm at that 5-year mark now. So it's, before that I was like, oh, I don't really get what they mean. Now I'm 5 years in, I'm like, oh, kind of get what they mean. So it's, I don't know. It's a hard profession. It's a wonderful one. And if you're in the right place with the right network around you, it is a wonderful one. But that's why we love doing the podcast, Brendan, as well, isn't it? We love doing that different side of clinical practice, talking about it and hopefully trying to give some advice and maybe think about teaching without having so much of the stress and the drama of being in practice all the time. It's a lovely little side hustle to have, isn't it?
I tell you that, when you meet people and they're working from home and they look fresh as a daisy and they've just finished at work. They've been for a run during the day and they've done a bunch, and they go, I've done a bunch of other things. And you think, well, you just said you're working from home and now you've done this, you've done that, you've been for a run, you've been to the gym, and now you're fresh as a daisy coming out of work at whatever. And you think, and look, there's lots of professions that have tough working conditions and ours is one of them. So, I come out of work, I get home, I've got nothing left to give. I eat and I go to bed. I am dead. I've been given everything to that day, and it's such a contrast to. Can I mention my? I don't know. If I mention my squash partner. This is, oh no, I don't get in trouble. No, it'll be okay. My squash partner, just like he's at the gym every day, and he kind of almost complains that it's a bit too easy. And I think, bloody hell, I wish I could have a bit of that in my life. Just a day at the work which is really chilled and nice. And I do think being a vet's got harder. We might have chatted about this before, but if you go back 15, 20 years, there was a dull bit in the middle of the day where we had 3 or 4 hours and not much going on. I don't really see that. In all the jobs I've had the last year anyway, I've not had that.
Yeah, I think if you work in a practice that isn't very busy, you're definitely the minority now. I think generally most practices are rushed off their feet all the time. So it seems to be that everyone is worked hard, really hard, from the minute you get there in the morning to the minute you go home. You're worked hard. And I think, as part of the reason why, definitely part of the reason why I became a vet is I wanted the challenge. I wanted to be busy. I think my body likes being a little bit stressed because I thrive on it a little bit, not a lot, a little bit. I thrive. And that's why I like ECC, because I like that little bit of stress because I perform better. But then I think there's definitely a tipping point where you go into when that's no longer healthy. My family always tell me, and my friends and Brendan, to say that, there's definitely a line where it becomes too much. And I think I cross over into that too much a hell of a lot more than I should do. Like I think a lot of people do in the profession, because we all think we should be doing more and we should be doing better. And it's a really hard thing to get a balance of, isn't it? But yeah.
Yeah. And it becomes a bit of a vicious cycle, because if you start getting stressed, you're doing more hours, you're getting more worried about things, you take more work home, you then start doing less out of work. So you haven't got that kind of freeing up your mind, because you're now, you've got your yoga class and your whatever. You're now losing a lot of the other things. Your social interactions start going less because you're now busier at work, you've got other things to do. Every year there's a point in the year where I go, I think I've got my work-life balance just right. And it's like it lasts for about 3 days. Yeah. And then within a month I go, nope, I haven't at all. I'm just as bad as I have been the last 26 years.
Yeah,
never.
Exactly.
So rare for me to get the work-life balance right. I know how important it is. Is it something to do with our brains? Like, are we making this happen to ourselves?
I think as well, the difficulty is that regardless of what the public might say, for how hard we work and for the emotion behind the job, the pay in veterinary is okay. Don't get me wrong. We're not paid awfully, but I don't think the pay is often reflective of the level of stress and emotional hardship that comes with it. And I think for that reason, the majority of vets and vet nurses will stay full-time. Full-time in a job that is as full on as ours takes a massive toll on your body and your life. And I think, the perfect thing to do in a lot of cases would be to go part-time. But with people needing mortgages and to feed their kids, and with how expensive everything is, it's not an option for a lot of people now. And unless you're lucky enough to be with someone who earns very good money and lives in the city or works in the city, for example, and can sort of help you with that financial burden, a lot of the time reducing that stress by working a bit less, it is not always an option. And yeah, non-clinical jobs are out there, but sometimes they're few and far between in terms of the ones that you really like the look of. So it can just be really tricky. I think the reason why we bring this up is not to say that, anybody that's not fully joined the profession yet or is new to it, like, beware, it's all awful. It's not to say that. It's just to say, make sure you keep track of yourself, make sure you keep track of your colleagues, use those services like FetLife. They're out there if you need them. Talk to people. And if you are struggling, just remember to have that conversation and say, right, what can I do to make my life that bit better? Because if I am struggling, something's got to change. So I think maybe things are getting a little bit better, and some practices are going to 4-day weeks rather than 5 days, and there's maybe more option for flexible working. And we're now talking about burnout and mental health more than we ever have done, which is great. But I think there's still a long way to go in terms of getting us to a point where less people are struggling and it becomes a profession that everybody is really enjoying and not feeling too stressed in. But yeah, I think there's a little way to go, but things are getting better, aren't they? I think generally over time.
Well, yeah, I think we're all in the same boat to some extent, or maybe mostly. And then I was going to say, part-time isn't always the answer either, because yes, you've got reduced income, that has other stresses on your life. But the other thing about being part-time is it can get more stressful because you're seeing less clinical cases. You don't feel as confident with the cases you are managing. It's really hard to be a part-time surgeon because you need enough caseload to just keep the fluency, keep the confidence. So there's difficulties. I don't know. End it on a positive note, Charlotte. You did a really good bit earlier to come back. Yeah.
I think it's just to say, be there for each other. Your colleagues end up being your best mates, really, because you spend more time with them than you do anybody else in your life. Talk to people. Make sure you're making time in your life to go to the gym or go out with your friends and your family. Make the time for the things that matter, because yes, we have an incredible career that really matters and we're making big differences in patients and clients' lives. But remember, your life is important as well and what you do with your life. So, just remember that you need to look after yourself as well. And I know this is like, I should be talking to myself too, because I don't take my own advice. But yeah, just watch out for yourself. Yeah.
Yeah. So
I know,
true.
like,
anyone who knows Charlotte will know.
Like pot kettle black, isn't it? But anyway.
So we've covered loads today. You brought up another controversial giant breed dog thing. Let's not have any hate about that. Horrible aspiration pneumonia cases. We did some dentistry stuff, burnout and vet med.
We hope as ever you've enjoyed listening, and remember to get in touch if you have any comments or suggestions to help us improve these pods for you, any topics you particularly want to cover. And remember, you've got the blog, you've got our WhatsApp number and the socials to contact us through, so please do get in touch.
Yeah, and put a review in as well on your Spotify or on your Apple Pods. It helps us get to more listeners. Join us again next Sunday for our extra bonus episode where we'll be diving into the world of endocrinopathies again, tackling Addison's disease and the Addisonian crisis.
Yeah, it's going to be a heavy one, but hopefully a really good one, and fingers crossed will be useful to you in practice. So we're looking forward to it already. Until then, it's bye from me.
And bye from me. Take care. Is intended for licensed veterinary professionals and is provided for educational and discussion purposes only. Whilst it is publicly accessible, it is not intended as advice for pet owners. The views shared are based on our own clinical experience and interpretation and do not replace individual clinical judgment. We accept no responsibility for decisions made based on this content, and all cases should be assessed on an individual basis. Any references to medications, treatments, or products are made for educational discussion only and are not intended to promote or advertise veterinary medicines to the general public. Veterinary medicine should only be used under the direction of a prescribing veterinary surgeon and in accordance with the UK veterinary medicine regulations.
This podcast may include paid partnerships or sponsorships. These do not influence our clinical opinions, and any sponsored content will be clearly identified.